Well, good morning, and thanks for having me here today. We have about 18 minutes to get this done, and there's a lot of information, so please feel free to come over and ask some questions once we're done here in the room. I'll be available and more than happy to chat with you. I'm also putting my email at the end of the presentation. I would love to hear from you, and you can find me in LinkedIn as well. Just love to chat. All right. I want to, in advance, tell you that the conversation that we're having today can be triggering for some of us. Sometimes it's even triggering for me. So when we're talking about end of life, and please know that you're in a safe space to show your emotions, to share them with us, to get up and leave if that's what you need to do. We're here to support each other. And perhaps to put that into context, I want to read these from David White. He's a well-known poet, which I love to hear. I could just hear him all day long. He says, "You are part of this long farewell that we all participate. You will say goodbye to others, and others will say goodbye to you." And in that context, let's talk a little bit more about palliative care services and hospice. I have nothing to disclose. And as I said, we are going to be talking about palliative care and hospice in the context of dealing with this ALS diagnosis. I also want to mention what are the criteria to be eligible for hospice services, and definitely want to discuss some about advanced care planning and give you some resources that you can utilize today. If you are going to take home any message from this talk, the only thing I want you to remember about integration of palliative care services into your journey with ALS is that we switch the narrative from trying to find out what's the matter with you, and we want to focus more on what matters to you. And imagine that every plan of care ever made for a patient started with that question: what matters to you? I think for once will save us a lot of time and saliva because we can get all carried away with putting all these beautiful, treatment plans together. And if it really doesn't make any sense or matters to the person we have in front of us, it really would not make an impact. Just a few weeks ago, my team called me and said, Dr. Jerez-Marte, we're really struggling with, I'm going to call her Mary. Mary's at home by herself with a diagnosis of ALS, rapidly progressing in the last 2 years, barely able to get around with her walker, has had a few falls, and she lives with her dog, Cujo. And she just doesn't want to leave the house. She doesn't want to be placed anywhere. But she also does not have anybody at home to care for her. She's already lost her ability to speak. She uses an eye gaze, and she has refused to use any ventilatory support like AVAPs. And I said, well, let me come and visit. Let's see what's going on. And I sat in her living room, and the first thing I see is this beautiful 70-pound pit bull that adores her. And actually, Cujo speaks, so he can say, "I love you." She's so cute. And, I asked, I say, "Hey, Mary, what really matters to you?" And she said, "What matters to me is to be able to spend more time with Cujo, because that is who really matters to her. And she knows that if she leaves the house and goes to assisted living or to a nursing facility, he cannot come with her. And she knows also that it's very difficult to place him, given his size and maybe his protective behavior." So our plan of care at that point completely shifted from trying to find out, why is Mary not using her cough assist? Why does Mary not being compliant with these medications that we have come up to treat, her excessive secretions and her pain, and she doesn't want to use this or that, to how are we going to help Mary stay with Cujo the longest she can? How can we come up with alternative plans? That everything shifted at that point. And that is what matters. What matters to our patients, what matters to you as a patient going through this journey. Now, ALS patients, most of you enjoy this interdisciplinary clinic thanks to associations such as the ALS Association. And so you are used to interdisciplinary care. You're used to not being cared only by one practitioner, but a group of practitioners all putting their heads together to help you do better and have a better lifestyle. And that's very similar to what happens with hospice. And I have to say that I had the privilege to spend a half day in the USF ALS clinic, and I was blown away. I thought I died and went to heaven. I couldn't believe the amount of collaboration that happens in between the care providers and with the patient and the family and their caregivers. It is just simply amazing. And I just don't understand why every single illness in this world is not treated that way, because it's so effective. So palliative care, when does it come to play? So palliative care can happen at any point as soon as you're diagnosed with a chronic life-limiting illness such as ALS. It can start at the very beginning of your diagnosis and run all the way until your very last days and beyond. So how does it work? You can have a palliative care team care for you to address initially, maybe while you're still highly functional and receiving more aggressive treatments and maybe involved in clinical trials. And that palliative care team is helping you deal with pain or other symptoms related to your condition or anxiety or the psychosocial aspects of dealing with this disease. It can also certainly be involved in once the disease is progressing, you have to be thinking more about advanced care planning, where and how you want things to happen as your disease progresses. And towards the end, and based on Medicare criteria, once we consider the prognosis being 6 months or less, there's hospice, which is another form of palliative care. Again, focusing on what matters to you, what are your symptoms, what are your psychosocial aspects and spiritual aspects of your care that need to be addressed. And beyond that, hospice also provides bereavement services for family and caregivers once the patient's no longer with us. So for up to 13 months, all included in the Medicare benefit, same with Medicaid, and most insurance follow the same rules, you can have bereavement services for the loved ones at no cost. So how does the palliative care model for an ALS patient looks like? I mean, it can be integrated in an ALS clinic. How about having a palliative care provider join your clinic? Something that would be very cool. It could be a separate specialty team that you visit in a clinic for palliative care services. Home base, which is also available in certain areas in Florida, where you can have a nurse practitioner, social worker, chaplain come and visit with you, so you don't have to leave your home to receive these services. Once leaving your home becomes very taxing. And there are other base forms such as telemedicine or at the end of life hospice care. We know that utilization of palliative care services decrease in necessary healthcare utilizations and ICU stays, meaning services that are not aligned with the patient's goals of care. You ending up in the hospital for symptom management that could have been already taken care of home, for example. And we also know, and I follow these numbers closely, that those patients who are enrolled in hospice in Florida end up less in the hospital. So the rehospitalization rate for a patient who's enrolled in hospice is only 2%, versus a patient who is not enrolled in hospice with a life-limiting illness is usually about 15%. So I want to leave you with a question. Is it worth integrating palliative care provider into your interdisciplinary clinic? How about, creating immediately those goals of care so the entire interdisciplinary team knows exactly what are we aiming for? With what frequency? Is it quarterly? Is it monthly? Is it maybe home visits to help with those challenging symptoms that sometimes are difficult to address in between clinic visits? And there comes hospice. The hospice philosophy is really to shift the plan of care from being so disease targeted, you're focusing on what medications are going to work for this illness versus we're going to focus more on the symptoms. And there's a term in hospice that was coined by Cicely Saunders, who was what we consider the founder of the modern hospice in the late 70s, that is called total pain. And Cicely understood that pain should be seen from every aspect of the human being, right? So not only the physical pain, the challenges that your body's going from, but also addressing the psychosocial pain, the existential pain, the spiritual pain. So there comes that integrated team, that interdisciplinary team to address all those aspects of your life that are contributing to suffering. So we focus now on how to mitigate that suffering, and not only for the patient, but also for their caregivers who are very much embedded into this situation. Hospice eligibility is dictated by Medicare, CMS, and Medicaid and other majority of private insurance follow the same regulations or recommendations. For ALS patients, we usually end up transferring that palliative care to a more end-of-life or hospice care once the patient starts struggling with their breathing. An objective way is if you have had those respiratory test, you get a forced vital capacity. Once you reach 50% or less, you're already kind of in a very difficult zone where your respiratory status continues to decline. That's a moment where you can be referred to hospice. If those respiratory symptoms continue to progress, despite, for example, of using your AVAPs, your non-invasive ventilation, also, if there's significant weight loss, despite all interventions that we've already listened to this morning, or you decide not to have feeding to place for supplementation of your nutrition, all of these reasons to initiate hospice services, because we're thinking that the disease has gotten to a point of significant progression and the life expectancy has shortened. We need a certification from your physician and from the hospice medical director saying that your prognosis is most likely 6 months or less if the disease continues its predicted course, which does not mean that if you make it to 6 months, you get kicked out of hospice. Although we love to graduate people, that's usually a very happy day. But hospice can be continued as far as there's progression of the illness. And remember President Jimmy Carter? The man has been in hospice for a whole year, and it's basically enhancing his quality of life without having to go back and forth to the hospital. He said it himself. I've gotten to a point in my life and in my illness that I need to focus on what my goals are, and going in having all these treatments is no longer fitting. So he continues under hospice care. And one of the reasons for a patient to continue hospice care beyond those 6 months is, again, continued decline. So when you enroll hospice services, you have a whole interdisciplinary team at your service. And these services are rendered wherever you live. It can be a home, a left, nursing home, wherever you're at. And it's there's the physician that's always in the background helping with symptom management, the nurse that does those home visits as often as you need them, depending on what's going on in your life at that point. There are counselors, social workers that can help you either connect with community resources, but also with the counseling piece for you and your caregivers, your loved ones at home. You have services like home health aides that can come to your home and help with bathing, getting you ready for the day. Usually they stay there for about an hour. We do not have under hospice care that custodial care, that one-on-one care of keeping somebody at home at all times. Unfortunately, there's really no program to provide that unless you have some sort of long-term insurance. But there are other things that, for example, can happen under hospice care, such as respite care. If a patient has a caregiver at home and the caregiver needs a quick break to go through a surgery, visit a family or something like that, they can go to a nursing facility for 5 days, all paid within the hospice Medicare benefit, while their caregiver is taking care of themselves, and give them a break. and then the patient eventually returns home. So we also have care centers, which I call like hospice hospitals, where you can go to receive, more intensity of care if your symptoms are becoming challenging until those symptoms are resolved, and then you can return home. So talking about symptoms, and I know you have a lot of concerns about those because I've heard, some questions this morning. The one symptom that I can tell you I often end up having long discussions about when I visit my patients with ALS is dyspnea or shortness of breath. Why? Because it's probably the scariest one, right? One cannot conceive that at some point, you couldn't really breathe on your own. And how does that look like? And a couple months ago, we dealt with a situation. I had a patient who's a veteran. I'm going to call him Ralph for the sake of this presentation. So Ralph came to us under hospice care. He's a veteran, and the military service people have higher incidence of ALS. And he came under our care. He already had a feeding tube. He was already becoming more dependent on his AVAP, on his mask for breathing, less mobile at home, was already using an eye gaze for communication. And when we visited the first time, I asked Ralph the good old question, what really matters to you? And he said, I want to be home when my time comes to die. But I also want to make sure that when I tell you that I'm ready, that you're going to be there for me and that you're not going to let me suffer through this. He was very concerned. So I said, gotcha. Let's develop a plan. What's the plan? And together with his loving wife, we put a plan together. And, what were going to be his words when he was ready? What was going to be the case? Like, what could make him ready? He told us, if I feel like I'm not breathing well and my symptoms are not well controlled, I don't want to drag this on. I don't want to suffer with this. And so it happened. It happened at midnight when Ralph started sending emails to all his loved ones, family members, saying his goodbyes. And so kind of hard to talk about this because it was beautiful to be able to assist him at that point. He then texted his wife, who was in the other room, and said, "I'm ready." And that was his code words. She knew what he meant by that. We had spent a few days that week struggling with getting his symptoms under control, and he said that he just didn't want to do this anymore. He wanted to be comfortable, which meant, based on the discussion we had, that we were going to increase the medications for comfort, which eventually, will make him less alert and less aware of his suffering. So we did. His wife promptly called the hospice team in the middle of the night, and they went home, and they had medications in hand that they could start using. By the time I found out around 7 in the morning, he was a little bit more comfortable, but still asking to please take the mask off his face. He didn't want this anymore. And we had a plan for that. And so I didn't want him to wait hours for me to get at the bedside. So I teleported with a telehealth call and put myself in the video and asked Ralph, who could still blink twice for yes and once for no. I said, "Are you ready?" And he said, "Yes." And I said, "Do you understand that I'm going to have to increase the medications we're giving you now to make you more comfortable so you're not aware when we take the mask off from you?" And he said, "Yes." And we increased the medication. In a few hours, all his family was at his bedside, his loving wife also there. And eventually, when we confirmed that he was not aware of what was happening, we removed the mask and he passed peacefully. So that's what mattered to Ralph, and that's what we made happen for Ralph. I want to mention palliative arts and recognizing that we're not only talking about medical interventions and treatment plans that require medications, they have a role throughout the illness to mitigate symptoms. And I put here with plus sign those that have really good data and studies to support its use, such as music therapy, which is great in decreasing anxiety and pain. You can actually measure the lowering of the blood pressure lowering of the pulse as these therapies take place. Same with massage therapy. And some that don't have very rigorous studies to really confirm whether they help or not. But Reiki, acupuncture, and aromatherapy are just delightful for those patients that respond to them. I recommend them and I encourage them to take them. Also, visual arts, visiting a museum. I was just watching, if you're not familiar, there is this documentary about Ember. Ember was a professor at Harvard in arts, and he was a painter, and he documented his journey with ALS, and he did it beautifully in the transition and how his art transformed as his disease progressed. Writing, this writing is for a patient. I went to visit him at the hospital and found him writing a poem about his blindness. He's legally blind. And he said, I just find solitude and find so much comfort when I write poems. That's my thing. So remember, there's a lot of other therapies that you can tap into. So quickly talking about planning and letting us know, where do you want to be at the end of life, and who do you want by your side? It's super important. And all advanced care planning forms that you find, and by the way, I brought some in there at the care services, the first table when you enter the next door room on the left. So these forms in most institutions are based on the 5 wishes, and which is well known in the end of life care, which is recognizing who will be making decisions for you in the case you're no longer making your own decisions. So that's a healthcare surrogate and an alternative healthcare surrogate. But also you let us know what do you want and what you do not want to be done to you in the case that you're no longer making your own decisions. Is it feeding tubes? Is it regarding to ventilation, to ICU stay, hospitalizations? Even the use of opioids at the end of life, you'll be surprised how often we struggle with family members that just don't know what you have wanted at that point. And they say, no to morphine, no to benzodiazepines. It's like, oh my gosh, we don't have anything to help you with right now. What are we going to do? Because, these family members don't really know what you want. So putting all that in writing is really important. And you can actually fill this out. I usually bring it to my talks, and surprising enough, I see a lot of healthcare providers filling them out because we are terrible at having our own, even though we tell our patients to make their own living wills in healthcare surrogate planning. So if you don't have one, please don't leave today without having one just written down. So all patients, and I say every human being should have a healthcare surrogate form and a living will, period, okay? Remember what David White says. We're either saying goodbye to somebody or somebody saying goodbye to us. So this is the one thing we have for sure, that end of life will come at some point and we need to be ready. Have in mind that these healthcare surrogate forms and living wills in Florida do not need to be notarized. So you can actually fill one out today and go home, and it's good and valid here in Florida. But some states outside Florida will require notarization. So there is a place where you can notarize it as well, so you can make it official in case that those states where you're traveling do not accept that. So I always encourage my patient that if you're a traveler, if you like to get out of town, please check with that state how these forms get handled and what is accepted or not. And other than the living will healthcare surrogate, there are what we call actionable forms and documents that you sign and that should be honored by EMS and a physician when they see a do not resuscitate form, which is our yellow form here in Florida, so that you don't receive CPR, intubation, and all these things at the end of life. And similar to that is the pulse, which is physician orders that are written more detailed, because there you can even put whether you want or not IV fluids, artificial nutrition, dialysis, transfusions. It can be even more detailed. So those are accepted in Florida. Some states do accept it, some don't. But I encourage you to have those in hands and make it part of your care planning. And this is how the pulse form looks like. And please, 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 why do you need a healthcare surrogate? This is the long list of people we have to go through if you have not written one down. Okay? It can get as low as needing to get bioethics committee involved. and having a social worker who's never met you before making end of life decisions for you. That's how terrible it can be. If you have several children, oh, God's sakes, please choose your favorite one. Or at least the one that you know will definitely follow through with your wishes. And by the way, if your spouse you know is kind of weak of heart and is not going to be able to make decisions for you at the end of life, just find somebody else to make those decisions for you. Have that conversation, which is most important, okay? I have a friend who works in hospice, and she says, my husband is not my healthcare surrogate. I chose my sister who will make decisions because I know my husband was just crying at the bedside and he's not gonna make a decision for me ever. So you need to choose the right person. Just have that in mind. Some recommendations, books. Atul Gawande, a surgeon who went through his own experience with end of life of his father, wrote this book based on that experience and how we're medicalizing end of life care to no end, and explaining why really there's other ways that we could deal with end of life. And BJ Miller, who is a palliative care physician, so if you want to write his name, BJ Miller, has this book, A Beginner's Guide to the End. He's really good at helping patients with chronic illness be acquainted and familiar with, the end, with dying, and making it a little bit more easy to process and discuss. And there's even a Netflix documentary where he appears that is called Endgame. I highly recommend it. So BJ Miller. And I left you also at the front desk here, again, next room, first desk to the left, these two books, one in Spanish, one in English, Hard Choices for Loving People. Hard Choices for Loving People, and there's for you to have. Please take them, either for yourself or your patients or your loved ones. It goes into more detail about things like CPR, feeding tubes, palliative care, comfort measures, and things that we didn't get to discuss today in very simple words, okay? So again, palliative care can benefit patients in mitigating symptoms related to life-limiting illnesses. Hospice is a continuation of that palliative care, and remember that it focuses in treating that total pain, psychosocial, physical, spiritual. Don't forget to have your advanced care planning in place. It's so important. And don't forget to reach out if you have any questions. Thank you. I'm going to take some questions if anybody has anything to discuss. We were turned off. Is it possible to put the last slide so my email can come up? We'll see if we can get it. There you go. Okay. There you go. And you can also find me in LinkedIn, and you can message me there. Same name, Jasmin Jerez-Marte. Right. Any questions? Do I have one? No. Here? Oh, here. I'm sorry, the light.
First, I want to thank you. This was beautifully delivered, so thank you for sharing your gift with the world. I have a clinical question, and I have my comment first is I'm the social worker at a multidisciplinary team in South Florida, and I find that I'm oftentimes the most comfortable going there with the patients as far as broaching the topic. And I guess my clinical question is, when you shared the beautiful story of Ralph, you mentioned that he indicated he's ready and you were going to up the medication. And oftentimes, lay people, we associate morphine with pain relief, but does that medication or others also help with reducing respiratory distress? That's my question.
Yes, and to answer that, yes. So it depends on the patient needs at that time. We always address pain, address anxiety, and address the consciousness part. Depends on what our goals are for that moment in Ralph's case, we had agreed that we didn't want him alert and aware when we took that mask off. You know, it's a compassionate vent withdrawal, we call it. And so those medications are addressing those particular needs.
Okay, thank you. And my comment is, when you were beautifully sharing the story of Ralph, it made me think, I reflect often that we as a society do an excellent job of preparing for new babies coming into the world to the point where we start monogramming things. But yet when it comes to the other big milestone, the end of life, we avoid it like the plague when we can plan for a beautiful dying experience. So what you painted was just picturesque. I want to thank you.
Yeah, thank you. Any other questions? Yeah.
So in our team, we, OT and speech here, we are at the clinic in Orlando here. A lot of times when patients will opt to do the hospice route, we've been told that therapies are no longer allowed to be part of that team. Have you, but I saw on your slides that you did say that therapy services were still allowed. So we get confused with that.
Yes. So, and thank you for asking this question. So are therapies allowed once you are under hospice services? So the one difference with hospice is that you are giving up your current Medicare benefit to change to the hospice Medicare benefit. So hospice becomes kind of your insurance provider, right? So again, everything in a much less convoluted way comes through hospice to get delivered to you. And there's also the controversy of having physical therapy, occupational therapy when you're already in hospice care. And the answer is yes, you can have it. If the hospice offers them, you can have them. They're not part of the core team, but they are services that should be offered by your hospice, and you should be asking for them if they're needed. Now the focus changes, and you talk a lot about energy conservation. That's mostly the focus. It's going to be energy conservation, it's going to be safety, it's not going to be restorative, which again, you know, depending on where you are in your illness, and usually by the time you're in hospice, those are what are needed. So yes, they can be continued.
Okay.
Thank you. Thank you for that question. I also want to add, and thanks for reminding me, something that we always advise patients before coming into hospice care is that if they're, let's say, waiting for an eye gaze machine or for a specialized wheelchair and some more specialized equipment that will be furnished through their current insurance, to go ahead and wait for those if it's possible. Of course, if things are getting fast, in, you know, kind of deterioration that is happening fast, you don't want to wait. But I did have a patient that we went to visit, and she went in hospice services. She was still waiting for her eye gaze. We said, you know, let's wait for a few days. We don't want to mess that up, because those are things that are not going to be provided by the hospice team. Okay. All right. Any other questions? All right. I'll be around. Thank you. Thank you so much.